Dr. Ruth Shim is the Luke and Grace Kim Professor in Cultural Psychiatry and Director of Cultural Psychiatry and Associate Professor at the Department of Psychiatry and Behavioral Sciences at UC Davis. Prior to these appointments, she was the Vice Chair of Education and Faculty Development and Chief of Outpatient Psychiatric Services at Lenox Hill Hospital. Dr. Shim has received numerous honors and awards and has been an advocate for bringing light to health inequities and the social determinants of health. She is the co-editor for the book, The Social Determinants of Mental Health. It is my pleasure to welcome Dr. Ruth Shim.
Thank you. I'm really pleased to be here with all of you, and I really enjoy leaving a lot of space for discussion. I do have some comments and some concepts that I want to make sure that we all are on the same page about, but then I want to fly through my slides so that we can have maybe a robust conversation at the end. So I'm going to get to it. So before I start, I always have to ground people in, if we're going to talk about structural racism, it's going to be difficult. And you know, you've been in this conference. That keynote was exceptional in kind of laying out these issues. So you're already primed for this. You don't need me to tell you. But these are complicated issues. If we're doing this work correctly, if we're making progress the way that we need to make progress, people should feel uncomfortable. There should be discomfort. There should be feelings of pain, of guilt, of defensiveness, if you're working through and coming to a place where you're going to have better understanding, better knowledge about these complicated issues. So I always like to prepare people for that place, that we are going to, by touching on these issues, you're going to feel some emotions. That's good. It means that we're moving in the right direction. And I like to remind people of James Baldwin's comments about this, which is that I'm not interested in anybody's guilt. Guilt is a luxury that we can no longer afford. I know you didn't do it and I didn't do it either, but I am responsible for it because I am a man and a citizen of this country, and you are responsible for it for the very same reason. So if you have those feelings, it's normal, it's fine. Use it as a moment to explore and to examine yourself. So as Wendy mentioned, I wrote a book a couple of years ago. I edited a book a couple of years ago with my colleague, Michael Compton, on the social determinants of mental health. And this is the conceptualization of those social determinants. And it's a bit of a busy slide, but it's really important to kind of get this concept down, which is that at the top, you have mental health outcomes, and particularly you have differences in mental health outcomes, inequities. So differences in outcomes in mental health according to different populations. The things that drive that are risk factors, social determinants, and then social injustice. And the things that drive social injustice are public policies and social norms. So if you start at the very bottom of this figure, you have the laws that we create in society, and you have the value that we as a society place on certain people and certain populations. We have social norms. For instance, I think that Dr. Chaco did an incredible job talking about how this government and the people of this government have not placed a value on Indigenous people in this country. So just an example of how we have created certain social norms, how we have decided that some groups are worth valuing and other groups don't deserve the same level of value. Those things lead to the laws that we pass as a society, and those laws then lead to unfair and unjust distribution of opportunity within our country. And that unfair and unjust distribution of opportunity then leads to the social determinants of health and mental health. So you see all of these things in the middle boxes here: adverse early life experiences, discrimination and racism, exposure to violence, interaction with the criminal justice system, low education, unemployment, homelessness, housing and food insecurity, and climate change and adverse features of the built environment. All of those things are the social determinants of mental health. They all lead to risk factors. They can be behavioral, they can be psychological, they can be physiologic, it can be in how people make decisions. But all of those things then lead to differences in health outcomes among different populations. And something that's really, the final thing I want to take away from this particular picture here is if you are intervening at the level of the risk factor, you are intervening too late, right? Because the social determinants have already been at play. And so we are taught in medicine, we are taught in health professional schools, let's intervene at the level of the risk factor, let's change the risk factor. But we must go further upstream. I thought you could go as far upstream to get to the social determinants. But then over time, I started to understand that that is actually not far upstream enough because those social determinants are in fact already in play. And the thing that's driving all of this is who we value as a society, the laws we pass, and then how those laws and how we value people, how we distribute opportunity and advantages and disadvantages in our society. So that is the level of intervention. If we're really serious about changing equity, if we're really serious about achieving equity, that's the level of the intervention. Okay, so just a couple of definitions really quick. Health disparities are differences in health status among different segments of the population, including differences that occur by gender, race, or ethnicity, education or income, disability, or where you live. Health inequities, however, are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And what is particularly important about this particular definition is it's saying that the laws that we pass in society and the value that we place on people create the differences in health that we see. That health disparities definition didn't talk about that. That health disparities definition often seats the difference or the problem in the individual rather than the systemic, avoidable, and unjust social and economic policies and practices. And if you think about all of the main differences that we see in outcomes in health and mental health, I would defy you to identify a difference in mental health outcomes that is not a health inequity. We often define these things and call them health disparities, but we're really actually referring to health inequities. And I think that also speaks to the challenges of our current state and the challenges of the United States, that we're not really able to state what we're actually talking about. You find that in other countries, they refer to these concepts as health inequities more commonly, but here in the United States, we stay with the concept of health disparities. Here are a couple of things that we need to think about in terms of definition. So, you know, the current state is one of inequality. There is unequal access to opportunities. Some people get some things and other people get other things. Equality is when you evenly distribute tools and assistance. And the thing that is so key about equality is we're talking about fairness. We're talking about what is fair, making sure everybody has the same thing. I often find this comes up when we talk about health professional education and what learners need. We often say, oh, if we do something for one group of learners, we have to do it for everybody, right? It has to be fair. We get stuck focused on fairness, and it leads us to this unrealistic goal of equality in which people don't get the same outcomes. So equity is the goal. Equity is one of the goals, and equity is when you customize the tools to identify and address inequality. And you can see with this picture, that's a good start, right? If you give everyone the tool that they need, then they're in a better position to move forward. The problem with that, of course, as you can see with this tree, is that if the tree is not set up to be equitable from the beginning, even as you give people the tools that they need, they will still be at a disadvantage. So justice is when you fix the system in order to offer equal access to both tools and opportunities, as you can see in this picture. You don't then actually need to customize tools if your goal is justice. You can actually work on fixing the system. However, that's hard work. The work of building the tools to reform the system is much harder than customizing the tools. So both, I think, are very reasonable goals. So there are lots of types of discrimination. There's legal or illegal discrimination. Legal, of course, is like Jim Crow laws, where you were allowed to separate people out based on race. Illegal is the way we practice most discrimination in this country now. For instance, racial discrimination is illegal, gender discrimination is illegal, and very recently now the Supreme Court has ruled that discrimination on the basis of sexuality is illegal. Those things, so now when we discriminate against people, we're often doing illegal acts in that discrimination. How those things are enforced, though, it becomes very different. There's overt discrimination where it's very clear what's happening, but there's also covert, which is more like microaggressions where you're not really clear on what's going on. And you're just left kind of scratching your head wondering what's happening. There's interpersonal discrimination, and then there's institutional and structural. Interpersonal is the area that we often spend most of our time focusing on. We spend a lot of time thinking about the one-on-one interactions that we have with each other and how problematic, we default to this. We default to this individualistic ideal. The problem with focusing on interpersonal discrimination is it gets us to this idea that we're dealing with bad apples, that we're dealing with a couple of bad people, a couple of problematic people, and the rest of it is fine. And if we can just weed out one or two bad apples, we can solve this problem. You hear this argument all the time. The issue, though, is, and I'll explain this in a couple of slides, that doesn't solve the problem. It's not a bad apple problem. It's, as you can see, it's not an apple problem, it's a tree problem, right? So it's an institutional, it's a structural level problem. And so the intervention has to be at the structural or the institutional level. So to define structural racism, it is a system in which policies, practices, and cultural representations and other norms work in various, often reinforcing ways to perpetuate racial group inequity. This system identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. And it is not something that a few people or institutions choose to practice. Instead, it's a feature of the social, economic, and political systems in which we all exist. And very, very, very important, structural mechanisms do not require the action or intentions of others. That is why when we talk about interpersonal discrimination or interpersonal racism, it doesn't really get to this issue of structural racism, because we can all be well-meaning people who do not commit acts of racism against other people and do not commit racist abuse against other people, and yet still we can harm people through structural mechanisms. And how does that work? If we were to eliminate interpersonal discrimination today, we would still see the same racial and ethnic inequities in health and in all the other areas that we see them due to the persistence of structural racism. We could have no interpersonal discrimination, we could have no bad apples, and we would still see the effects of racial and ethnic inequities in our society. A couple of other concepts that I think it's important to define, and this relates a lot to how we teach about medicine and health. One is this idea of essentialism, that there is a belief that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization, that we put people into these categories. This is how we are taught in health professions education. We're taught to categorize people. We're taught to put people into categories and make quick decisions in order to save lives. The problem is, while doing that work, we have to understand the concept of essentialism and how if you do that characterization all of the time, you are bound to start making errors in the ways and the beliefs that all people are a certain way, all people from one group behave in one way or present in one way or have the same beliefs, to have the same values, or have the same genetic makeup. So that is the risk of essentialism. There's also this concept of positionality and invisibility, which is when you don't see or examine or question the unnamed norm. And we do this a lot in health professionals education. The norm is a white male, often a heterosexual white male. And we kind of paint that norm as the normal. And then we compare all other groups to that person as if, or that group of people as if that is the norm. And so in mental health, we do this a lot, right? We have diagnoses of depression in which women have higher rates of depression than men. And we often try to link that higher rate to things like hormones and say that the depression rate has to do with estrogen levels. And yet we don't ever look at testosterone levels. We never look at how testosterone has an impact on aggression. We never examine if that has any relation to differences in outcomes, because we see that group as the norm, and we see that group as the unquestionable norm. And so that is normal, and everything else is abnormal. Erasure of context is when you fail to consider the socio-historical context in seeking to understand the etiology of inequities. This is described to perfection in a book by Jonathan Metzl called The Protest Psychosis, How Schizophrenia Became a Black Disease. And he basically describes that in the rise of the 1960s, there was a change in the diagnosis of schizophrenia. It used to be that mostly white women who were having challenges in their home life, where they had desires to work outside of the home, or they weren't interested in being homemakers, they would be diagnosed with schizophrenia, and they would spend a year or so in a very supportive, very nurturing psychiatric facility. And they would be diagnosed with schizophrenia, and then they would return home to their families. But at the rise of the civil rights movement, there was a shift, a dramatic shift in the diagnosis of schizophrenia. And there was a group of psychiatrists that started calling out a particular type of subset of schizophrenia that they called the protest psychosis, where they said that these Black men were aggressive, they were challenging authority, they were paranoid about white people, and they were not deferential to law enforcement or to people in positions of power. And that led to an overdiagnosis of African-American men and African-American people who were fighting for civil rights, being diagnosed with, and possibly experiencing stress in that fight that led to psychotic symptoms, but that being contextualized as related to some sort of pathology that was not there. To this day, we have high rates of misdiagnosis of schizophrenia, overdiagnosis of schizophrenia in African-American men. They're more likely to be diagnosed with schizophrenia than with mood disorders like bipolar disorder. And that relates to the same inability to understand the context of the moment and the historical context of the moment that you're in. And finally, biological determinism is this false belief that racial groups are biologically and genetically different. And the real sad thing about this is that this type of idea is still being taught in health professional schools today. It's not universally being taught the way it was when I was a medical student, but it is still actively being advanced. And the reason is because the people that taught the people that teach students now were taught by people who believed unquestionably in biological determinism. Okay, so there are many types of structural racism. There's the war on drugs. I feel like that doesn't really need to be commented on. There's residential segregation, which is redlining, which also I think people really understand. There's immigration policy, which is how you structure who comes into this country and who doesn't, and how you specifically prevent people that have mental health problems or other health problems from entering the country as immigrants, therefore creating a healthy immigrant effect. Therefore creating this concept of, oh, people from this country don't have this particular illness, when that's not accurate at all. It's just the ways that our policy is structured. The Social Security Act of 1935 is that act that created retirement for older people and allowed people to pass wealth on to their children and not be anxious and stressed in their older and in their retirement years. But the Social Security Act, in order for it to be passed, Southern senators required that it did not include domestic or agricultural workers, and those domestic and agricultural workers just happened to be overwhelmingly African-American in the South. And so they were excluded from the Social Security Act and were not allowed to build wealth and pass that wealth on, and were not free from anxiety or stress around in their older years. And finally, mental health care, which we'll talk about a little bit more. So in 2018, 69% of Black adults with any mental illness received no treatment. 67% of Latinx adults with any mental illness received no treatment. And 42% of Black adults with serious mental illness received no treatment, and 44% of Latinx adults with serious mental illness received no treatment. That is majorities of people with mental health problems that did not get any treatment. And it is a significant amount of people with serious mental illness not getting any treatment. And also, it gets very disturbing when we look at substance use disorders. The overwhelming majority of Latinx adults with substance use disorders do not get any treatment. And 88% of Black adults with substance use disorders do not get any treatment. And what's really interesting about this is that we have a narrative, we have an idea of why this is. And we say, oh, people from Black and Latinx populations, because of their culture, have a lot of stigma, and they are against seeking mental health treatment. And that seems like a very reasonable narrative. And you know, we have interactions individually with our family members, and we think, oh yes, because people make comments, right? But the truth of the matter is that stigma is not any greater than any other stigma of any other group, including the unquestioned norm. Because really, when looking at Black Americans in particular, this study found that cost was the most commonly cited reason for not seeking care. So that really high rate of people not getting treatment, the reason that they said they didn't get treatment was cost. And it was twice as often as minimization of symptoms. It was nearly 5 times as often as stigma as the reasons why people weren't seeking care. And I will also just add that the other issue is they didn't even talk about discrimination. And the number of people who experience and perceive discrimination when they're seeking mental health services. And so if you've experienced discrimination when you're seeking services, you are also less likely to engage with that service going forward. So there are a lot of other reasons other than the narrative in which we have kind of denigrated certain cultural groups and said that they have deficits, which is what we often kind of default to instead of thinking about all of the other contexts by which people aren't seeking care. So in the last few seconds that I'm going to talk, I'm just going to say a couple of things about how we can think about dismantling structural racism in both health and medicine. First thing we need to know is that political stances and policy interventions are required. If you're going to remain apolitical or neutral, that in and of itself is a political stance, because it is a tacit acceptance of the status quo. So we cannot afford to be neutral. There is no acceptance of that. That is accepting the current state, and that is a political statement in and of itself. And then I love this quote by Audre Lorde. She said, when we speak, we are afraid our words will not be heard nor welcomed, but when we are silent, we are still afraid. So it is better to speak. In the last few seconds, I just want to talk about this one concept that is particularly relevant right now in trying to think about how we're going to move forward. So progress is made through the passage of legislation, through court rulings, through other formal mechanisms that aim to promote racial equality. And we have made a lot of progress over the years. We've moved in a really positive direction, but I think it's really important to be prepared that with progress comes retrenchment. And retrenchment refers to the ways in which progress is very often challenged, neutralized, or undermined in key policy arenas. We are seeing extreme examples of retrenchment based on policies that we've passed and progress that we've made. If you're not prepared for that retrenchment, you can get hopeless, you can feel overwhelmed. We need to be prepared for that. And so, to keep us hopeful, here's a quote from John Lewis, who said, "Do not get lost in a sea of despair, be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never ever be afraid to make some noise and get in good trouble, necessary trouble." And do I have any time left for questions? Because I'm finished. Good, okay, great. Tried to speed that up.
We'll just have one round of applause for Dr. Shim.